So my first blood administration, I had a young lady who was ejected, had multi-system trauma. She had a right lower leg fracture, right femur, upper leg fracture, pelvic fracture. She ended up lacerating her liver, took out all of her ribs on the right side, so she had a hemopneumothorax, so her lung was collapsed and it was bleeding. On top of that, she ended up having multiple subarachnoid small bleeds in her brain. So when I get to her, no radial pulse, no femoral, weak carotid, completely unresponsive. A lot of the research was showing that if you have these patients who are in a class at the end of class 3 or class 4 hemorrhagic shock, if you intubate them, you've increased their mortality by another 10 to 15% just by putting a laryngoscope in their mouth.
Sounds right. Welcome to In Service, the EMS Podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle.
Today's guest is Lieutenant Dave Kleiman with Cobb County Fire and Emergency Services. Dave's career in medicine started long before most of us ever touched a stretcher. As a combat medic in the United States Army, where he cut his teeth on trauma medicine early and learned what aggressive hemorrhage control really looks like. After the military, he transitioned into civilian EMS and has spent more than 3 decades as a paramedic, educator, and system builder, now serving in quality improvement and continuing education for Cobb County, a veteran paramedic, educator, and one of the people helping push pre-hospital trauma care forward in Cobb County. Dave has been instrumental in building the county's pre-hospital blood program, bringing packed red blood cells and plasma into the field for patients who would otherwise never make it to surgery. We're also talking about hemorrhage control, from rapid bleed control with trauma gel to tourniquets on the street, to TXA stabilizing clots, and how stopping the bleed early gives trauma patients a real chance to survive. We'll also get into canine officer treatment protocols, the legal and operational challenges behind them, and what it takes to build systems that actually work when seconds matter. Let's get into it.
Hey, welcome. Good morning, Dave.
Hey, good morning. Thank you, sir.
Yeah, I'm glad you could make it in today. Today we're going to be talking about blood and blood products in the program that you've spearheaded over in Cobb County. So that's working for you. We're also going to talk about TXA, trauma gel, and tourniquets and how that fits into the program, because it's probably equally as important.
Very important.
Yeah. And then we're going to round out with some canine officer treatment protocols and what you've been doing with that as well.
Awesome. Well,
Yeah.
Thank you for inviting me in. I'm looking forward to this.
I'm glad you can make it on a Saturday morning on your day off. Let's get started. Where'd you grow up? Where are you from?
I'm actually from Cheyenne, Wyoming. I am not a Georgia native.
Well, neither am I.
I have spent more of my life here than Wyoming, but I'm actually from Cheyenne, Wyoming. And parents got divorced, and I moved from Wyoming to Georgia for my high school career. From there, I went into the military. And then when I got out of the military, I decided I'm not going back to the snow.
Yeah.
I said, nope, I actually like the urban life. And I said, I'm coming back to Georgia.
Yeah. I've always enjoyed the snow. I like skiing and snowshoeing and all the winter activities. I hate shoveling.
That's me.
I've spent a good deal of my life shoveling snow. I don't want to do it anymore.
Well, I told my daughter, we're talking, half inch, quarter inch here, and snow apocalypse. We're going to shut all of Atlanta down. But I was like, our school buses had snow plows on the front, and Dad would throw me out the second-story window into 8-foot banks, and then I would meander my way to the bus stop, and the bus would shovel its own snow to go to school, you know? I love skiing. I love snowmobiling.
Yeah, snowboarding.
But, yeah. That's one thing that I tried to get into, because I take my daughter skiing all over, the East Coast. We're trying to make our way to the West Coast. But I tried that snowboarding. I can't.
No, I can't do it either.
I tried so hard because I was like, oh, man, I wish they had this growing up, but they didn't. I'm good at skis.
Yeah.
I couldn't get that either.
What'd you do in the military?
Believe it or not, I was a medic in the military.
You don't say.
Yeah, go figure, right? It's funny because growing up, I was looking at war movies, all our age. Grandparents were in the military, uncle was in the military.
Yep.
So my stepdad was in the military. When I was looking at it, I was like, hey, I want to go in the military. I don't want to be a frontline guy. So I started watching all these war movies, and the one guy that everybody called on was the medic.
Yeah.
And I said, man, that fascinates me. I had no clue about EMTs, paramedics, or whatever. So I went in the recruiter's office. I was like, I want to be the guy in platoon. When somebody gets shot, they're going, Doc. I said, that's the guy I want to be. And he was like, absolutely. So I signed up to be what at the time was a 91 Bravo, which is your combat medic. So I went in the military, and the military taught me how to be an EMT and paramedic. So I actually got certified. Back then in the military, they didn't keep your certs up. So I was actually certified as a paramedic, worked on an ambulance at Fort Hood, Texas. And then when I got out, I had to go and redo all my EMT and paramedic certs.
So they don't require you to maintain the credential.
Thank God the military had a shift. So now if you go in and you're a 68 Whiskey, which is the newer version of combat medics, they actually maintain your certs for you. So that way when you come out, it's an easy transition right into an ambulance, fire department, or going into PA school.
That's awesome. So what originally pulled you into EMS coming out of the military?
Well, when I came out of the military, I was blessed that in the military, most combat medics get attached to mechanized infantry, armor divisions, artillery, whatever. Luckily, that's not where I went. I had a buddy who was attached to mechanized infantry, and so literally all he did was go every day to the motor pool, fix his little armored ambulance, and did nothing until they got deployed. When I got to Fort Hood, was like, we're going to attach you to the hospital division. So I actually worked on an ambulance, and so that's what's actually gave me my love of it, because I was on an ambulance as an 18-year-old in the military. I look back then and I go, I didn't have a clue at the time, but we're all government property. So the stuff I was doing, chest tubes, venous cut downs, sutures, surgical crikes, stuff that I didn't know you couldn't do in the civilian world. So I was out there doing it as an 18 to 21-year-old, having the time of my life.
Coolest stuff in the world.
I was like, this is awesome, Cardiac arrest would go into the military hospital. They would pronounce them dead, and they were like, come here, Dave, and we'd close the curtain. Hey, do a chest tube, do this. And I was like, God, this medicine is awesome, because we're all government property. When I got out of the military, I was in during the Clinton era, and so he downsized the military. So I was not allowed to re-up. Well, I could have re-upped, but I would have had to go for infantry. And I said, I'm not doing infantry. When I got out, I came back to Georgia, and I immediately was like, hey, I'm going to go work for, believe it or not, AMR, because they were doing the ambulance for Cobb County and Fulton County.
Yeah.
And so I was like, I'm going to go do there. So I actually walked into AMR's doors, and they were like, okay, we need to see all your certs. And I was like, certifications? And I did have national registry in the military, but I didn't know about recerts.
Yeah.
So at least I was blessed that they said, hey, you need to go get your license back. They pointed me towards North Metro Tech, which is now Chattahoochee Technical College. I actually went back there and had no clue. They only do classes once a year. By the time I came into them, it was January, and I had to wait a full year to go in. So I went and did retail, which just solidified that I needed to get back in EMS.
You're doing what you were doing in the military and then going into a retail environment probably was a hard transition.
It was crazy, let me tell you.
Now, how long have you been a medic?
I've been a medic since 92, so I've been doing this over 30 years. I did have that small gap when I had to do my recertifications again. So it's been about 30 solid years.
What's your current role?
My current role for Cobb Fire is I do quality improvement for the whole county, and I also do continuing education.
So over 30 years, any calls stand out to you?
I've had several. From the military side, you know how it is after 30 years. There's certain calls that stick out.
Yeah.
And I think the call that sticks out that helps solidify blood products was way back. I had a soldier that I had to go to a motor pool, and he was, whatever reason, 18-year-old, jumping in the back of the track where they open it up to let all the soldiers run out. he actually had his leg caught in it, so it was amputated. Wow. So back then we didn't have tourniquets, because remember, tourniquets fell to the wayside. So we had those mask trousers, the pants that you used to pump up.
Yep.
So our treatment was, we're going to do all these little pants on you. We're going to pump you up. And then, of course, our treatment back then was, hey, we're going to give you as many IVs as we can. We're going to give you a lot of IV fluid, and you drive to the hospital where the surgeon's going to save your life. So there I am as a 19 or 20-year-old on an ambulance. Put this guy in mask trousers. He's still awake. At the time, I look back, he's probably a class 3 hemorrhagic shock. So I got a 10 gauge in each EJ. And then I got a bunch of 14 gauges in him, and I gave this guy about 6 liters of fluid. Well, back then, that was the standard of care. So by the time I get him to the hospital, I had somebody I put in the ambulance who was semi-conscious, who I was like, woo, I'm going to save your life. And by the time I get to the hospital, I'm pumping on this guy's chest. These doctors at the hospital are high-fiving me. Fantastic job. You got bilateral EJs, because we didn't do IOs at the time.
Right.
So he was like, you saved a life. Or didn't save a life, but hey, I did my job. And I looked, and I was like, this dude dead. You know, I didn't know at the time that I helped facilitate that. But then there was that call that stuck out, and then you can look through the years where there was no hemorrhagic control, no TXA, no tourniquets, and story after story of that stuck out to me, where there was no permissive hypotension, and I was just giving people liters of fluid, and I was doing washouts.
Right.
Because pre-hospital back then, we weren't data or science driven. It was, throw everybody on the backboard. And then they're going to sit at a hospital for an hour or so. And now we have ulcers on these patients, and they're geriatrics. And, next thing you know, they're septic and they're dying because we put them on a backboard. So it was a blessing that I've been in this long enough. And just like you can actually see how the science, we are now following suit what the hospitals have been doing for, 100 years.
It's all evidence-based now.
Yeah, perfect, evidence-based. And so I'm tickled to death that the evidence base is coming out, and the hemorrhagic traumas right now are leading the cause on evidence base. You know, right. we have other stuff that's following suit, CPAP. So there's other stuff that's coming out, no backboards, but it seems to be trauma on the evidence base is what's leading the change in pre-hospital right now.
So when we talk about blood and blood products, what problem are we actually trying to solve here with that?
So it's a twofold. When we're talking about blood products, the first thing is we got to stop the leak in the dam. So hemorrhagic control in today's pre-hospital world is incredible. Tourniquets, because of all the wars, the evidence bases came out. So we are able to stop the bleeding. We've got TXA, trauma gel, some good hemorrhagic controls where we're able to stop that. It's nice to see that the pre-hospital blood, somebody is finally, a couple doctors, Dr. PL, Randy, they've been leading the cause to say, why aren't you guys doing what we've been doing in hospital?
Right.
Pre-hospitals to the point now where they can actually stop or slow the bleeding down. But our biggest thing with pre-hospital blood is if we don't replace the oxygen, if we don't get the red blood cells back to perfuse the brain, the heart, the lungs, and in my opinion, the kidneys, because I sure don't want to be on dialysis.
Yeah.
If we can perfuse those, we can buy time at the hospital for them to do proper scans, come up with a good game plan, and actually be able to give somebody a nice, easy surgery instead of some down and dirty in the middle of the ER bay.
I read something recently that said blood loss or hemorrhage will kill you faster than a breathing-related issue.
I'm telling you, it's mind-blowing. One of the studies I read shows that if a hospital if they have to do a massive transfusion, that's a 33% mortality just for them to do a massive transfusion to try to save your life.
Wow. And
then if you're in a class 4 hemorrhagic shocks where you actually have a loss of a radial pulse, especially a femoral pulse, and then on top of that, you're actually unconscious to the point where they have to intubate you, that's a 50% mortality. So there's your 50% mortality, and then we're going to go to the hospital, and then we're going to add another 33%. So your chance of survival is almost, less than 20%?
Right.
So it's amazing that this pre-hospital blood has been pushed across the U.S., and we're still in our infancy phase. With some of the stats that I was talking with Randy, who's been leading the pre-hospital blood. She's really been pushing across the U.S. Out of something like 15,000 services, there's 264 of us, if you take the helicopters out, that are actually doing pre-hospital blood. And that's less than 1% of the nation.
Barely scratching the surface.
Absolutely scratching it.
At what point did you become convinced, outside of your military experience, that crystalloid therapy alone was no longer acceptable for hemorrhagic shock?
I think the selling point for me was I've always been involved really heavy into tactical medicine. I was on our specialty team, and I started looking at the military. The military pulls out some beautiful evidence-based. So a couple years ago, they had something come out called permissive hypotension. They've shown by data that if we give you more than a liter of fluid, we're actually going to bust all your clots. That's actually having a systolic greater than 80 to 90. So there's two different papers. One says 80, the other one says 90. But if you try to keep a systolic of 80 to 90, if you go higher than that, you're going to bust every one of those clots that you've either stopped with TXA or some sort of pressure control. So you're going to bust all those clots loose and kill people. So I read these science. I believe in the science. And then, so I actually had a patient who was actually T-boned. And so I got there and looking at her vital signs, she was a class 2 going into a class 3 hemorrhagic shock. And I was like, oh, perfect. This is the perfect person to do permissive hypotension where I can actually see it in action. So I went to go give her the permissive hypotension. And that first 250 bolus, I was keeping her right in that systolic range of 80, right? Then we were trying to extricate her from the vehicle and asked somebody else, hold this IV fluid, just barely keep it dripping. Well, they open it up as we're trying to extricate her, and all of a sudden, boom, she goes unresponsive. And then I look at it, and I go, oh, the bag of fluid's empty. And so it was an inadvertent, we're going to open it wide open because this patient looks like it. And that's when I learned as a teacher, you really got to start pushing it system-wide. Because this patient now, she wouldn't have had a good outcome anyway because there was no pre-hospital blood and we were out in the middle of nowhere. But for me, that was true evidence that, hey, permissive hypotension at low fluids, because you and I both know this crystalloid fluids, all I'm doing is increasing volume.
Right.
And if they don't have enough blood, in theory, if I give them enough fluid to push that blood to the vital organs and we get there to the hospital fast enough, we can actually try to stabilize them enough for the surgeon to do their job.
And I think the goal was always to try and drive that systolic pressure.
Back in the military, it was you get as much fluid because, not evidence-based, the more volume I get, if you have 20% of your red blood cells, and if I give you 80% of that back in crystalloids, I'm going to push that red blood cell where it needs to be. Now it shows, the evidence shows that that's not true. What you're doing is you're thinning that 20% down to maybe 10%. You might have increased the volume, but you've thinned out the red blood cells, so the ones that you are pushing around, you're destroying the clots. Any clots that they've made, out the window. And I'm not delivering enough red blood cells to get oxygenated to get where they need to be.
That's fantastic. So what is the data telling us?
So there's several datas throughout the nation that you got to look at. All right, so if you look at just like the Cobb County data, so we'll stick with that right now. So we're still in our infancy phase. We actually just did administration number 56.
Wow.
So that's incredible since we launched on February 14th, National Donor Day.
So a little less than a year now, right? 11 months?
Correct. So with our data, and I've got good data for 52. We'll go back to 52. Out of the 52 administrations, we are at 81% that are actually going home who have been discharged from the hospital. We've shown on some of those, on 8 of them, were class 4 hemorrhagic shocks. Class 4 hemorrhagic shocks have a 50% mortality. 8 of those patients walked out of the hospital or pushed down in a wheelchair, but they've survived hospital discharge. Our data has shown that pre-hospital blood, the sooner we get it in, it actually takes these patients from a class 4 hemorrhagic shock towards a class 2 hemorrhagic shock, where the hospital can now give them blood at a smaller rate, have more times for the scans, to give these surgeons a good time to sit there and say, okay, this is how we're going to treat. And I'll give you a story that shows how it works. I was a believer, but never saw it. I'm going to give somebody blood in a class 4 hemorrhagic shock who's going to wake up. So my first blood administration, I had a young lady who was ejected, had multi-system trauma. She had a right lower leg fracture, right femur, upper leg fracture, pelvic fracture. She ended up lacerating her liver, took out all of her ribs on the right side, so she had a hemopneumothorax, so her lung was collapsed and it was bleeding. On top of that, she ended up having multiple subarachnoid small bleeds in her brain. So when I get to her, no radial pulse, no femoral, weak carotid, completely unresponsive. A lot of the research was showing that if you have these patients who are in a class at the end of class 3 or class 4 hemorrhagic shock, if you intubate them, you've increased their mortality by another 10 to 15% just by putting a laryngoscope in their mouth.
Right.
So I was in the back of the ambulance. The guy I was working with from Puckett, he was like, I'm going to intubate her. I was like, wait a second, just bag her. The evidence says that if I give her blood, I'm going to reverse all this.
Is this because you're stimulating the vagus nerve?
Correct. And, they're already struggling.
Right.
They've got no volume. They've got no ejection fraction. The heart rate's already in the 150s. And if we would put a vagus in there, and that 150 is the only thing stimulating enough volume to actually give her a carotid pulse and somewhat perfuse the brain. So imagine if you put that laryngoscope, you're going to knock that down.
Yeah.
So I give, and we'll come back to how we set our program up, but we ended up already having good tourniquet control, gave her the 2 grams of TXA. So now we're going to support any internal clotting mechanisms and stop her body from destroying those clots. And so I give her 1 packed red blood cell. That brings her carotid up strong. I give her 1 gram of calcium, give her a plasma. She instantly wakes up. So that was the moment solidified for me. When you have somebody who's completely unresponsive, who you're about to intubate, and in my career, I've had so many of those patients, and I'm sure you have too, where as soon as you intubate them, you're pumping them on the chest and they're dead.
Yeah.
And so for me to give her the TXA, packed red blood cell, calcium, plasma, she wakes up to the point where we're not even having to bag her. She's talking to us. She tells me all her name and everything. My mind's blown.
Usually doesn't go that way.
She goes from unresponsive to looking at us, and I'm all giddy in the back. This is the first time I've had a good adrenaline rush in 30 years. And I was like, oh, my God. And my partner, he was like, well, what do I do? And I was like, put her on nasal cannula. I got to finish pushing the plasma and putting some saline in her.
This is uncharted water.
Totally. And then, of course, I'm like, everybody's going to be like, oh, Dave Kleiman, he just wanted to get blood. Because now I'm like, did she deserve blood? And now I'm questioning myself, even though I know from 10 seconds into the call she needed blood. But we get to the hospital, and this is what solidified it for me. We get to the hospital, and of course, they're all like, I turn the patient over, and I go out, and they're like, hey, we're going to do a big PR event in the bay of the Kennestone Hospital. So I'm doing a little PR, and then my medical director who was working comes out there and says, come here, you got to see this. And we walk back in, and they literally have like a whiteboard, and the surgeon's writing stuff on there. And I was like, because you gave her blood, you took her from a class 4 to maybe a class 2, she didn't get blood for another 45 minutes. They took their time. They gave her all these scans. They actually came up with a good surgical plan. Hey, when do we need to do the lung? What's the first thing? Okay, we got to get her a chest tube. When's the next thing? And they had a whole game plan. And the surgeon was like, I haven't had a chance to do this in a trauma in a long time.
Wow. That's fantastic.
So to me, that was what solidified for me that, hey, man, why have we not been doing pre-hospital blood in 30 years?
Yeah. And you have an ejection. That's the last time I read anything on it was 80% chance of death, 80% mortality rate with somebody who's ejected.
Yeah, especially if you're talking about blunt traumatic.
So why is the civilian world so slow to adopt blood and blood products when the military's been doing it and flight programs have been doing it for years? Is there an answer to that?
I don't know if there's a true answer because it's different for every state.
Yeah.
So unfortunately, one of the things that dictates a pre-hospital blood program is where do you get your blood? There are like Red Cross and Life South Community Blood Bank, they'll happily give it to you, but there's so much regulation right now because it's so new. So you've got the state regulations, you got FDA regulations, and then you have the AABBA coming in, the American Academies of Blood Banks. There's so much regulation, and there's no clear, okay, guys, this is what you do.
Yeah, you're mapping it out.
We truly are, and luckily, we didn't invent the wheel. Our blood programs are heavily run or pushed through the medical directors. If your medical director is not on board, it's not ever going to happen. Our deputy medical director, Dr. James Infazan, came from Orlando, where he helped start their blood program. He went down there for an EMS fellowship. When he came back to Georgia and Cobb, he became our deputy medical director, and he was like, let's try to do pre-hospital blood. And Georgia is still in its infancy stage. You had Hall County do it, and then you have plasma being done by Spalding. Grady, thank God, was already leading the way for us. It was easy for us to say, well, Grady's doing it. We're just going to do a heavy QA version. And then it was easy for us. The hardest things for most services that I've helped is, and I tell them immediately, find your blood before you start looking at what state applications, what education, what equipment do I need to carry. First thing you need to figure out is where I'm going to get my blood. Because we all thought it was going to be as simple as like what he did in Orlando or New Orleans or even in San Antonio. In San Antonio, I don't know if you watched that video, they actually had to do a very creative way of getting their blood, and that's what I wanted to do in Cobb because I thought it was as simple as, I just go to my blood bank and go, here's what we're going to do.
Give me 10 units.
We were going to be modest because you got to be really good stewards of the blood. So we were always going to be modest. Hey, give us 1 or 2 units of blood, and then that way we can immediately get it back to that blood bank or the hospital because, blood's a precious commodity.
Yeah.
So we thought it was going to be as simple as, hey, blood bank. Man, blood banks are hard. They are really hard to get blood from.
Yeah.
So for us, the biggest, and I look back now, it's only been 11 months, but I look back and I go, hey, that's actually a blessing in disguise because it took us 2.5 years to get to that February 14th launch date. And it was interesting. We had the blood bank on early, and then the blood bank said, nope, not going to happen. So then we were shopping for blood. And while we were shopping for blood, it was interesting. We decided to start pushing out. How do we set up 1 unit for the whole county to give blood? And so for us, we have 1 unit, our medical operations team. And so that 1 unit has got to get all over the county. It's got to do an intercept with an ambulance if they can't get on scene. And so how do we set them up for success?
Right.
So what we did is we pushed out heavy tourniquet use for all of PD, SO. We even started doing it in school systems, started pushing out a big stop the bleed. So, hey, if we get somebody else to do tourniquets before our unit gets there, we've stopped the hemorrhage control. Then we started looking at hemostatic agents, and that's when trauma gel came along. And I'll circle back to that. But I was like, perfect. So now we'll get every ALS unit to carry trauma gel. Now we need something in case this patient is that blunt trauma. How do we get him that clotting in there? So, hey, let's get TXA all to the ALS stations. And it's interesting. We pushed out IOs, humorals on everybody, BLS cruise tibias. And so it was interesting that out of all of our now 55 administrations, our team has only had to do 5 IVs or IOs in the back of an ambulance. And we've only done 1 tourniquet ourselves. It's interesting that in that blessing of 2.5 years trying to find where we get our blood, we had enough time to set ourselves up for success. That 1 unit that's carrying blood, everybody does all the work. We get the glory. I gave the blood, but it couldn't have happened if PD wasn't there and did a tourniquet. If our Cobb firemen didn't get on scene, start good vascular access, give the TXA, make sure they keep them in permissive hypotension for us so when we get there, the patient's perfectly set up. We can give the blood and plasma, and we get the Lazarus moment, and all of a sudden now they're at the hospital, and these people are walking out of the hospital.
So all the time-consuming interventions that need to occur before the blood are happening by the time you're getting there.
It would never happen. And all the intercepts we done, or when I've made it on scene, everybody has it set up. All I got to do is look at the patient, look to see do they qualify for blood, and then giving the blood. I've got to make a 1-minute decision, a minute and a half or so to set up all the equipment to get the blood going, and then give the blood. Blood takes about 2 minutes to give. Then I've got to give about 60 seconds worth of calcium and flushing out the body, and then turn around and give it another. So it's amazing that in 10 minutes of our average transport time, if the TXA hasn't been given, typically it has, the TXA is given, the plaque red blood cells, the calcium, the flushing of the system, the plasma, the flushing of the whole life flow system, and then we have about 2-3 minutes to spare where we're back there and talking to a patient who we should have been pumping on the chest.
Yeah. So let's talk about the blood products you're using. Give us a little overview of that.
So we originally was trying to get low titer whole blood, right? But that was not going to happen. So when we partnered up with Life South Community Blood Bank, they were very honest to begin with. They were like, you're not getting whole blood. So we then looked at, hey, what is blood component therapy? So there's a lot of papers out there from Dr. PL and Dr. Hantevi that shows blood component therapy is par for pre-hospital as whole blood. And so what we did is we are carrying 3 packed red blood cells, O positive, and then we're carrying 3 plasmas. We just put it into a second unit that's up and running from the same station. So we've had several instances where we were on scene where we've had multiple patients that could have received blood, and you're only having one unit that has one heater that can give blood to one person. So we didn't want to, we stopped it from our crews having to make a decision. Does patient A get the blood or patient B? So now we have those 2 units where both those coolers are going to those scenes.
Wow.
So, but we're using blood component therapy to circle back to you. When I've talked to different people throughout the U.S., it's a blessing that I spent 2 years doing EMS videos prior to being the first one to administer blood. And they were like, we need you to do this PR. And at least I understand and appreciate, and I think I'm fairly well spoken. So like when I help people throughout the U.S., a lot of people are so focused on whole blood. Now, whole blood is the superior product.
Right.
Because we got our clotting factors in there. But blood component therapy, those few services that are using it and that are pulling the data, it shows that from a pre-hospital standpoint, it's cheaper, it's easier to keep it. You got a longer shelf life, and it's superior. I mean, it's on par with whole blood. So why not? Don't focus and don't handcuff yourself to go to some product, whole blood, that you get 14 days out of. Pack red blood cells, 28 days.
Yeah.
You know, the plasma nobody takes back. But we have a thing, Life South Community Blood Bank, where we keep the product for 16, 18 days, and then they sell it back to the hospital system. So we're being very good stewards of our packed red blood cells.
What are you getting with the plasma? What time frame is that? You said they don't take it back.
They don't. So we get our plasma, and by the time it comes through doing all the regulations and stuff, we get it for about 21 days. Most places are not going to have it 28 days unless it's coming from there. So we get about 21 days.
Wow. So tell me about TXA and how you're deploying that.
So
trauma gym.
Well, so the military did a fantastic, and then it actually got pushed. The military was doing it forever. And the military was showing that if we're giving the TXA, and then the CRASH 2 and 3 study trials came out, which was worldwide, but it has shown that the sooner you give TXA, it stops the body from using plasmagen to break down what fibrogen's already in your body. When I got multi-system trauma, my body immediately deploys the fibrogen and starts that clotting cascade. So it tries to aggregate the platelets there, so it starts a nice healthy clot. The problem is your body, homeostasis, it doesn't know, okay, all this fibrogen's going here. So it starts to break it down and releases plasmagen to break down the fibrogen, right? And so what TXA does is it stops the plasmagen from potentially breaking down that robust clot that's being formed. These CRASH 2 and 3 trial studies in the military prove through evidence-based that the sooner you give somebody TXA, the higher likelihood that they're actually going to make it with that robust clot and make it through surgery or make it to surgery.
Right. Right.
So for us, we were blessed to have 2 medical directors, Dr. Nix and Dr. Impazan. They truly believe in this. And so when we pushed out TXA, we used to give it 1 gram in 100 mLs and give it over 10 minutes. Well, the military and the evidence base and CRASH 2 and 3 trial studies show, hey, give it in 2 grams. And so when we do it, we give it to all of our ALS units are actually pushing 2 grams IV bolus. And then that's actually what's helping us set us up for success. It's funny, most people's protocol, and ours was forever. It was 1 gram into 100 mLs and given over 10 minutes. And like I said, the CRASH 2 and the studies all show that, hey, 2 gram IV bolus. In the military...
When you say bolus, what are we talking about?
Well, we're not doing an adenosine push.
Right.
We're just doing a nice, slow, not necessarily like cardizem, but, we're not slamming it in there.
Yeah. So walk us through your system design.
All right, so you're talking about from like exactly what?
How does it, and you can give us a 10,000-foot view of this, but take it from donor to administration.
So people come into a donation center and they're going to give their blood. If you go to Lifestyle Community Blood Bank, what they'll do is you get a donation, and then that will go to its facility where they'll make sure they're FDA compliant, make sure type and cross, and make sure all that stuff.
Right. They're testing it for potential pathogens.
Correct. So what will happen then is that we will order plaqued red blood cells and plasma. It comes in the back door, and we go and actually take claims, sort of way we take the blood, make sure that it's still in temperature range. There's no clotting mechanisms. Everything looks good on it. We all put it into our Delta cooler and take physical control of it. At any moment, that unit is working 24 hours a day, 365 days a week. When we started down this road, we had a high school intern working with our EMS chief. And while we were trying to set up the program, he was like, we got to have some sort of number to tell the county commissioners to say, hey, make this viable. And so this high school student, it was amazing, did her job. She came up with 72. She said, if you guys start a blood program, there are 72 trauma patients you can give blood to that you'll either save their lives or make a significant difference. So we were like, okay, hey, if we're going to do a blood program, let's not just do traumas. Let's encompass all medical patients, and let's encompass pediatrics. So we were looking at somebody with esophageal varices, varicose veins, OB calls, anything. And so that took it from 72 to about 200. So we set our protocols up. We set 1 unit up. We were actually trying to shoot for the moon. Give us 5 units, hoping they were going to give us 3. They gave us 1 because you got to make sure the program's going to work and you're being good stewards to the blood. So we have 1 unit. Once they pick up their blood, they take control. They're there at their station. Any hemorrhagic call that they potentially get blood, they're immediately dispatched early.
Right.
So we were looking at how do we get that 1 unit. The way we get that unit there faster is by those call classes. Dispatch will be there, and we already set it up with dispatch. Boom, they're on the initial dispatch. Is the unit driving all over the place? Absolutely. But they have the potential to get there on scene. If the patient needs blood, boom, they're either en route, make it to scene, or they can sit there and do what's called an intercept, where the ambulance doesn't wait for us. They'll start transporting the patient to the hospital, and then we're looking on a map and saying, hey, we're going to meet you at the intersection of so-and-so. We made everything portable. Our guys just step in the back of the ambulance, keep going to the hospital. Some of those intercepts, we've only given the patient packed red blood cells. Just giving that patient 1 packed red blood cells, it saves it from the hospital standpoint of having to do massive transfusions, giving them time to do scans and stuff. So that's how that little portion of the system's set up. We're really good stewards of the blood, and we're blessed with Lifestyle Community Blood Bank that when we get to that arbitrarily date that they set, we give the packed red blood cells back to them. They don't take the plasma back, but we give them the packed red blood cells so that way they can make sure it gets to a hospital or a doctor's office, whoever needs the blood. Right. And that way they're still good stewards of the blood.
Wow. So here we go, right? This is where I'm reading my question. I was like, what the hell? So what were some of the earlier design constraints on the system you put together? Outside of the blood, obviously, acquiring it.
So we were looking at, state of Georgia, there's 2 different types of regulations. There's regulations of transporting blood, and then there's regulations of you holding on the blood, potentially give it to a person. So that restraint is the blood's got to stay within 2 to 6 degrees Celsius. So the first thing is, how do you maintain that blood? So there's different types of systems out there. You've got ones where you have like the big refrigerator unit, that's specific for blood, and it's got the cool little thermometers. I can keep it right at, let's say, 4 degrees Celsius. If I need the blood, I open up the refrigerator, I take them out, and I put them in my cooler with medical grade ice packs, and I can go to the call. That's the cost is astronomical. And then you look at a human part. So if I'm working on a 24-hour shift, for me to have what's called a cold chain record, I have to make sure that those ice packs are rotated out. I got to have a temperature on that blood. I got to make sure it stays within 2 to 6 degrees Celsius. There's a human error or potential error where I have to ask a fireman who's running 24 hours. Remember, they're not just giving blood. They're still going to fires, going to extrications, going to fire alarms. So I need you to get up every 4 hours, go make sure you have a log of exactly what the temperature of the blood was, the plasma was. Got to make sure all that kind of stuff.
Right.
So that's a big human potential error. So what we did is we looked at, hey, what does the military do? The military leads the way in everything. So the military has what's called a Delta RP. The Delta cooler is self-sufficient and technology-based. So this cooler, I can literally do a 3-meter drop and it's still going to work. I can actually plunge it in water, pull it out, and it's still going to work. It's set up for the military to the point where if I'm a flight medic in the military, I can look at the cooler and it'll tell me the degree of the helicopter pitch is too much. The compressor is not working, so I got to fold it up. And then it's so smart that if it's just on a battery, the battery lasts 96 hours, but the battery actually looks at 2, 4, and 8 hours into the future. So depending on my ambient temperature, like let's say I'm in Afghanistan at 140 degrees, it will say, oh, my battery's good for 23 hours if you don't change the ambient temperature.
Right.
The technology is so good, it's tied into everybody's phone, right? So we have 24 people's phone that I can actually look right now and say, this is what the 2 coolers that our blood products are in, this is the exact temperature. I know if that lid gets left open or every time the lid's open because everybody gets an alert on their phone. So we can be even better stewards of the blood products because we know. And then on top of that, when we go to return the product, Lifestyle Community Blood Bank is looking at our cold chain records. They're like, this is incredible. You can see it every second until it's either administered or returned. We have a picture-perfect cold chain, and we can say it's perfectly within range. So the first part is that cooler. The state of Georgia says we got to have warm blood. So once again, we said, well, let's look what products are out there, and then what does the military do? So there's a product called QuinFlow. QuinFlow is military. Military keeps making smaller and smaller stuff. So the original QuinFlow looked like a small version of a grandfather clock. Now this thing is probably about the size of the water bottle. And this thing, if you think of a tankless hot water heater, as soon as I plug the CDU, which looks like a foam block, I plug it on there, hook in my blood tubing to it, right? As soon as I flush the system, it takes my blood, after the system's flushed, it takes the blood and goes from 34.4 degrees Fahrenheit. And by the time it comes out to be administered in the patient, it's 100.4, and it maintains the 100.4 until you're either finished with all your products or until the battery, which lasts for well over 8 hours.
That's fantastic.
And more importantly, it's all compact. So all we have to do when we step in the back of an ambulance is our little merit bag that's got all of our LifeFlow, the QuinFlow in it. It's got all our medications, and all we have to do is carry the Delta cooler. So for us, logistically wise, and when I try to tell people, set yourself up for success, I was helping Douglas Fire do that, and I was like, there's several warmers out there in the market. You need warm blood, but this is the fastest way. What can we do in 10 minutes? Because we average, and 10-minute transport time is what we did. We pulled the data and said, okay, you're going to have 10 minutes when you step in the back of the ambulance to get to either Kennestone or Grady. What can you do in 10 minutes? This set us up for success because you have a fluid warmer that takes less than 10 seconds to warm up ice-cold crystalloids to warm, and then by the time the blood gets there, by the time it comes out the other side, 100.4.
Wow. How has the medical oversight been?
So this is all medical director and QA driven. We got to make sure we're good stewards. The blood that is administered in Cobb, as soon as it's administered, it's heavily QA'd. Did the patient qualify for blood? Did this make a difference? We actually make sure that the report suffices the state of Georgia, FDA, and the ABA's rules. We do follow-ups on the patients to see, because this is a human product, there is oversight from the FDA. Does this patient have a bad complication due to the blood? So there is very, very heavily QA'd on this, but this is all medical director reviewed. If you don't have a medical director who buys into pre-hospital blood, your service is not going to have it.
Yeah.
I know I want to circle back to how you set yourself up for success, if you don't mind.
Sure.
So one of the big components, tourniquets. We all know you got to have tourniquets. The commercial-made tourniquets nowadays are incredible. I just tell people, make sure you get something that's TCCC certified, because there are some tourniquets on the market that are not that way. Something else that helped set us up for success was hemostatic agents. I try to tell people, look at the hemostatic agents on the market. One of them that we actually did a clinical trial of, which is trauma gel. Trauma gel is an incredible. It's a plant-based hemostatic agent. And what's interesting about trauma gel is it starts your factor 12, so it starts your clotting cascade, right? So it starts that clotting. From a surgical standpoint, it's easily removable, but it doesn't manipulate your clot. So we are doing a trial of Seal hemostatic spray. We've done Kaolin. We've got our quick clot out there. But those, when they remove them, you have the potential of removing the clot. And so for us, from a hospital standpoint, they love the fact that Cobb Fire is using trauma gel that starts the clot, supports the clot. We're still doing good bleeding control. We're still doing TXA. But from a surgical standpoint, they don't have to worry about, well, when I remove it, am I going to pull that clot, and then I've got to be more aggressive to stop the bleeding. It's already clotted itself, and you don't manipulate it.
How was that administered?
So it comes in a 30 ml syringe, and so you actually just plunge it. You use a 4x4 to make sure, hey, I've got the gross blood out of the way. I can see where the entrance wound is. And then I put the tip of the syringe right to it. I do a slow administration, and trauma gel is so malleable, it actually traverses the geometry of the wound. It takes the place of wound packing. Our administration likes it because now we don't potentially having somebody use their finger with a 4x4, sticking it in somebody and potentially getting bone fragments, bullet fragments, or that kind of stuff.
Pathogens into the wound.
Correct. So it just travels and traverses the wound. It actually fills in the temporary cavities and the permanent cavity.
Wow.
Yes.
That's pretty fantastic.
Hey, it's Jason Falvey. Thank you for spending part of your day with me here on In Service. If something from this episode hit home, maybe it reminded you of a call, a shift, or a hard lesson learned, follow the show and please send it to just one person and ask them to follow. Now let's get in service.
So what would you tell a similar-sized agency that wanted to replicate your program? What would you tell them not to do?
The biggest thing for not to do is don't get so focused on, I've got to have whole blood. Look at blood component therapy, right? And then don't just, if your local blood bank says no, or the Red Cross says no, don't just go, okay, it's not going to happen. For us, when we started looking at other things, Chief Adams came up with, let's look at Life South Community Blood Bank. That's now something I tell people all the time. And they're like, our blood bank's not going to do it. Red Cross not going to do it. Look at these other services. You know, Life South Community Blood Bank only does the Southeast, but there's a version of Life South up north. So the biggest thing for them is look outside of the box. San Antonio started their own donor program to start their blood program because they were having issues. So there's stuff out there.
How do you address the psychological barriers here? You got providers out on the road. There's got to be some resistance there to it, right?
Well, for
hesitation, fear.
There is. But the thing about it is, when we chose our one unit, those were guys who had their passion was EMS and tactical medicine. So for them, it wasn't so much a hesitation.
They were eager to do it.
They were eager to do it. Now, it'll be interesting because we are going to try to expand the program outside of them. One of the things about it, even for me in my first administration, It was just like the first time I ever criked somebody. I know they need to do it, and then you sort of got to talk yourself into it.
Right.
For me, on that first crike, my partner finally was like, "Are you going to do this or not?" And I was like, "Oh, yeah, okay." And it was the same thing for the blood. The patient qualifies, and I was like, "Yeah, I'm going to do this." So there is a little hesitation. I think more people are excited about it because it's at the forefront.
Yeah.
So, I mean, there's one doc, and I'm trying to think of his name, but he said, and this is just so exciting for me because I came up with the LifePak 5, right? So defibrillators were always out there.
Right.
But defibrillators is what changed cardiac arrest for pre-hospital.
Right.
Blood is the version of a defibrillator for trauma patients. And I've witnessed that firsthand with the blood. You know, me giving people blood who are in a class 4 hemorrhagic shock. They're unresponsive, not talking, you know, weak carotid pulse. And I give them the blood, and it's amazing. It's like an MMA fighter. You know, when he gets knocked out, the ref steps over him. And as soon as the blood gets back to that guy's brain, what is he doing? He's wrestling. Every one of these patients that I've given blood to who've had that Lazarus moment, who wake up, it's amazing because the moment when they went unresponsive, they come to, they're immediately asking, I was doing this prior to the wreck, or I was doing this prior to whatever violent crime or whatever was the trauma that put them in there. And the lights come back on, and it's right then.
Wow.
It's absolutely mind-blowing.
What's the hottest skill to teach here, or the hardest skill to teach here?
So for me, it was the Jehovah's Witnesses. When we were setting up our protocols, we brought in one of our Jehovah's Witnesses and said, explain to us why you will not take blood products. It was reminding our guys, you're potentially going to give blood to somebody. Most of these patients are unresponsive. There's only been a few that have been talking, the majority of them. So you still got to make sure you get some sort of consent. We need you to do a little more due diligence. Have somebody go look in their wallet for the Jehovah's Witness little card that says, hey, I do not want blood products, and it's all signed. Go look through the purse. Take the few extra minutes to make sure. One of our first hesitancies was we're carrying O-positive blood, all right? With the O-positive blood, there is a chance. We were originally under the thing, make sure when you're giving this O-positive blood to any woman of childbearing years, you're going to potentially change their RH factor where they might end up later on when they get pregnant, there's a chance that they're going to abort their own fetus. The first time I gave blood in my first 3 administrations was on females. I'm coming to the hospital, hey, this is why they qualify. It's O-positive blood. Hey, doc, you hear me? O-positive. Okay, we got to get him the RhoGAM shot. You know, make sure we change all that. And it's interesting that the science has now shown that on blood component therapy, it's still mixed data, but it takes anywhere between 6 and 12 packed red blood cells to potentially change the RH factor. So now you don't even worry about that. So now it's one less worry for us. But your due diligence on the Jehovah's Witnesses is something that I would have never in 30 years on a trauma patient go, hey guys, let me see the purse. Let me look at the wallet. Okay, I don't see a card. Do you see a card? No. Okay, we're going to give her blood. Because that is the one thing that you need to make sure you do take the few extra moments.
Yeah. How do you prevent protocol paralysis?
We actually have very robust protocols. When we looked at that on other stuff, hey, if they've got to meet 3 of 5 criteria to give blood. We made it real simple so we wouldn't have paralysis. We said, guys, our protocol is systolic less than 90, MAP less than 65, heart rate greater than 110, end tidal less than 20. We used end tidal less than 20 because that captures the end of class 1 going into class 2 hemorrhagic shock. And we made sure there was no paralysis by going, they don't need all 4. They need 1. Your clinical judgment saying, due to the MOI, in that one piece of that protocol, this patient qualifies for blood. So that's how we prevented paralysis. You need 1.
So what's the ongoing training look like?
So in the state of Georgia, the way it goes is you have a threefold. You have the organization that actually will submit the paperwork to the state saying, hey, we want to do a blood program. Once you're approved, that's good for 2 years. Educational standpoint, You have your initial education, which is driven through the medical directors. Now my job is I submit that stuff to the state and get state approval for initial education for your protocols, your procedures, the PowerPoint, what we're going to teach, all the complications and indications. And then the state of Georgia, you have an annual competency. So every year I got to go out, and I just finished up all of our guys who are PLS, post-licensing skilled certified. I go out and make sure that they are good on all the protocols, and then more importantly, all the procedures. So I actually make them go through, actually set up the life flow system. We use the life flow to get the blood products in as fast as we could instead of me squeezing it into a warmer. The life flow system, I can give a packed red blood cell in less than 2 minutes. If I had whole blood, it'd be 4.5 minutes. So I make sure that they know how to set up the blood, they know how to use the life flow, how to use the Quinn flow, and then I give them complications that they have to work through to make sure that they're doing it.
Wow.
So that's a state requirement, which everybody does who's been.
Have you seen a shift in mindset for people that maybe were skeptical about the program?
It's funny because when you're looking at an organization as big as ours, there's going to be outliers. So everybody who is on the team is excited. They understand the benefits of blood. But we do have those outliers who are like,
yeah, it's super cool. Why wouldn't you want to?
yeah. But you do have those outliers. So I've been in medicine 30 years, just get them to the hospital. It's amazing to see those people who have been on scene, who have witnessed it, who are like, dude, this is incredible. These are people who are like me, been there 20, 30 years. Most of these trauma patients, you pump on the chest, they don't survive. For them to see them wake up. I had a traumatic arrest, blunt traumatic arrest. They're pumping on his chest when I arrive on scene. They just defibrillated him. They intubated him. They are pushing epi 1 to 10,000. I'll do my due diligence. Let's see if this guy qualifies. For our traumatic arrest, we look to see, did they go into arrest within 10 minutes, or is there something that's going to show they have viability? In my patient, he had pupillary response. And because he has pupillary response, I know he still has oxygen to his brain. So as I'm giving him the packed red blood cells on scene, as they are rolling him onto the backboard, they're like, hey, I think he's breathing. And then they feel, and they're like, man, we got a carotid pulse. And for me, when I'm giggling in my head, I'm looking at these guys on scene, and these are all salty old paramedics, a bunch of new EMTs. And for them to see the wow moment from their eyes, I was like, this is awesome. And then I gave that guy 2 packed red blood cells, 2 plasmas. And then 32 days later, he walks out of the hospital. Blunt traumatic arrest.
Wow.
I mean, do you know the survivability on a blunt traumatic arrest? 0.07%. I mean, this guy in the back of the ambulance, when I was just finished up the second pack red blood cells, he opens his eyes, yanks out. They put an eye gel in him. He yanked the eye gel out. And he's like, talking and all this pain and stuff. But you're like, I mean, this is awesome. A blunt traumatic arrest who I can give you story after story in my 30 years. I'm pumping on these people's chests, and you're like, this guy never had a chance.
You kind of know where it's going.
Correct.
This changes all that.
All of it.
So how has early blood changed scene management or transport decisions?
So it's kind of interesting. We originally said anybody who gets blood goes to a level 1 trauma center. But then you have those outliers. We're giving blood to somebody who's in a traumatic arrest situation. You should always go to the closest facility to make sure that you airway secure and all that kind of stuff. We've actually shown with these patients that we're giving blood to, these patients who are either in traumatic arrest or in class 4, which you've got to protect an airway still. And you're like, all right. So a couple of them, we gave blood and went to the closest facility. And now you're talking about you bring somebody back from class 4, and now you have to have these surgeons scrambling to either do something they haven't done in years, or we got to transfer them out to a level 1. And so now the scene management has came to the point where even if these patients are unresponsive, we give them blood and they wake up, or we stabilize them, take the extra 10 minutes and go to a level 1 center. Because now our pre-hospital blood has shown that we've stabilized them so well that we can make that extra transport distance to get them to the most appropriate facility.
Has there been a situation where it didn't change the outcome. You gave blood and you didn't see an improvement. What'd you learn from that?
Well, so the one call that comes up that I was involved in, we had a patient who had to be extricated from underneath a semi-truck, right? Patient was non-seatbelted. There wasn't a lot of outward trauma. Was there potential for internal trauma? Absolutely. She qualified for blood based on the MOI, based on the vital signs. Gave her the blood. I was expecting, well, here comes my Lazarus moment.
Right.
She didn't come to. Then we do another thorough assessment, positive Babinski. She ended up being neurogenic shock.
Right.
So there are those multi-system traumas across the nation where you have to do a rule out.
Because you don't know, right? There could be a ruptured spleen, lacerated liver. There could be some internal.
And this is the reason for push for pre-hospital ultrasounds. If we had the time, we had the training, we had the equipment, could I have done a fast exam on her and go, okay, she's not actively bleeding. This is probably neurogenic shock. But when you don't have that ability out there yet, and it's not, the pre-hospital ultrasound will come probably within the next decade. But in that case, you have to do your due diligence and say, well, in case this is hemorrhagic shock, I'm going to treat. Because if I don't, well, and I'm just like banking my whole buck on this is neurogenic and she ended up being hemorrhagic shock, well, I've assisted her into the ground.
Right.
So, there are those moments where we have those patients. And the data has been shown, New Orleans, San Antonio, we have to do our due diligence and say, in case this is hemorrhagic shock. We have had those cases in Cobb.
How do you define success with this program?
So for me, personally, was and I'm telling you, it's crazy, out of my 9 administrations, 7 of them, Lazarus woke up, and then these patients walk out of the hospital. So for me personally, our data has shown we've had 8 people in class 4 hemorrhagic shock who would have never survived if it wasn't for the pre-hospital blood. Data, not only from us, but New Orleans' data that they published that shows the same thing. Grady's published their data that shows the same thing, that pre-hospital blood, even if those arguments of, well, you're 2 minutes away from the hospital, the sooner we give blood on, we're stopping them from going up that hill of death.
Right. Wow. So you've got some other things going on here too. Let's talk about development of canine officer treatment protocols.
So it's interesting. When I first got on our tactical team, they told me, you're responsible for officers. And I was like, yeah, not a big deal. I'm good in trauma care. Then I looked and I said, well.
We got blood, man.
Yeah, exactly. We looked and we said, canines, the canine officer, this is a valuable asset for any police department. I have 0 veterinarian skills. So I started pushing my EMS chief, who was over our specialty team. I was like, we've got to come up with something, and of course they had a couple little classes where, oh, hey, here's how you give fluid. But I'm like, well, I want to know how to intubate this dog, because these dogs, they're putting these assets, these canine officers, in on these houses and cars and stuff to save a human life, and the dog's going to get shot or stabbed or something. And the only thing they showed me was, if your dog's in, get some pre-fluids on board, or if your dog is potentially a heat emergency, here's what you're going to do. And I was like, well, where's the trauma care? So our EMS chief, with me being a little chihuahua, he sent myself and 2 guys to New York City with NYFT to learn how to do canine medicine. And so when I got up there, FEMA is the one that was teaching the classes. They have all these cadavers that we're going to practice on, along with live dogs to do assessments. And they do their due diligence. They were like, hey, guys, in your state, this is what you can do. This is what you can do. Where's the Georgia boys? All right, you guys can't do anything we're going to teach you for the next 5 days. And I was like, what? And they were like, well, we can't find any state law to protect you as a provider from intubating a dog, doing an IV, pushing drugs, anything we're going to show you to do. So I get all this valuable knowledge, and I come back and I tell the EMS chief, this is what we're going to have to overcome first. We're going to have to overcome some legality issues to protect our guys. We do active shooter training every year. either once or twice. This was several years ago, but we were at this active shooter training, and I was one of the instructors. We had all the canine teams up there. So we shortened every class. Class period would be an hour. And, we do little hour classes, and then eventually we do the big scenarios. So we cut the classes down to 40 minutes so they could go out to their partner in these vehicles and make sure they get the water, walk the dog, that kind of stuff. As I finish up one of the classes, I'm walking out in the parking lot to open up the cooler to give everybody water for their dogs and themselves. One of the handlers comes rushing over and says, "Hey, my dog's struggling." This dog ended up being a hyperthermic cardiac arrest. By the time he brings the dog out, and I'm like, "Go call everybody." So he brings out Officer Chase, and Officer Chase is in full-blown cardiac arrest. I start working this dog. I intubate the dog. At the time, we don't have the actual true endotracheal size. I had to use the biggest tube I had, and the 15-millimeter adapter is just like right at the end of the canines. I'm having to keep my hands in the dog's mouth to hold the tube so I can bag the dog. Luckily, one of the guys that went to New York is there with me, so he gets vascular access. We start working this cardiac arrest, and the drugs are basically pediatric doses. Then it comes into my mind, I'm like, well, where do we transport this dog? And we always had a rule, an unofficial thing with the local ambulance provider. If we ever call, you guys will transport it. Absolutely. So I got all these handlers and all these other cops there and all these firemen there, and they're all in the parking lot watching me and a small group of people work this canine officer, Officer Chase. There we are doing...
Which is a cool name for a police dog.
I loved it. I loved it. So I'm like, all right, guys, I tell all the handlers, I said, I need you to start calling animal clinics, because I thought just because you have the word emergency on the side of your vet office that you could handle everything.
Right.
So I start calling local vets, and they're like, you have a hyperthermic cardiac arrest dog. And I'm like, this dog is potentially going into DIC, disseminated vascular coagulation. Can you handle this? Absolutely, don't come here. The emergency clinic we normally would transport to, just so happens that day they're not open. The other one is not open. They're calling around to anybody that can potentially handle this dog. We're in northwest Cobb, and the closest they find is off Delk Road. Finally, the ambulance gets there, and we start transporting this cardiac officer Chase in cardiac arrest, hyperthermic. We're trying to cool him off. We were using bottles of water. We dumped water on him. We got Monster energy drinks, believe it or not, packed up in the groins and stuff, and we're pumping on his chest, and I'm pushing epi. So I called the vet en route of Emergency Veterinarian Hospital.
He's never in his life gotten a phone call
No. So I called Dr. Shee, and I'm like, my name's Dave Kleiman. A handler told you I was coming in with cardiac arrest. All right. I'm like, Doc, this is where I'm at. What am I missing? I need you to push atropine. And I said, my brain's fried. Tell me a dose. Here's your dose. So we get all the way down there, and kudos to Dogwood and Dr. Shee. They did everything. I mean, they worked for an hour to save Officer Chase's life, giving blood products. I'm coated in the dog's blood because he went into DIC en route. Back of the ambulance looks like a mess. I call the EMS chief, and I'm like, well, no, I did it. I worked Officer Chase. So now he's calling the state and saying, hey, how do you guys want us to handle this PCR and stuff? And that was the critical moment where I said, okay, you can't have two guys out of 18 that has a clue. The third guy was about to retire. I said, you can't do this. We've got to have this. I'm blessed in 30 years. I was EMT and paramedic instructor. I sort of understood operational stuff. And I said, you know what? Let's create the canine medicine the way human medicine is. So I asked Dr. Shee, will you become our canine medical director? And so we wrote protocols, we wrote procedures, and then I took it a step further. I said, what is these handlers' medical care that they get for their dog?
Right.
And so they didn't even have any care. We're going to give you a $100,000 asset, but not teach you how to take care of your dog in emergencies. So we trained every handler that wanted to come. I invited every city in Cobb County. And so what we did is we trained every handler on all medical emergencies, and our guys were in there too. All the medical emergencies, all the basic trauma care, everything. Hey, your dog has potential GDV. How do you decompress? Where are you going to transport to? Hey, here's the poisonings. Here's what you're going to do. They ended up getting kits donated, so every handler has a little first aid kit with everything so they can handle that. Our guys went through all that training too. And I said, now let's take our guys to ALS. So our guys learn how to do IVs. They learn how to intubate. They learn how to properly do compressions. Here's your drugs. Here's how to cool the dogs. And then so what we did is send them to clinicals. So all of our guys went to clinicals at Dogwood. So that way they could practice all this on live dogs, because we're practicing all this in cadavers during all the training, because you have to have, there's no high fidelity mannequins for canines. There's a couple in the market, but they're so expensive.
Yeah, I would imagine.
So we practice all that. There was a political side where you got to make sure all the county commissioners are on board and understand, and the public safety director, okay, this is the training, why they're doing the training. And so everybody's on board, and we do all that training, and we do clinicals. North American Veterinarian EMS Association actually has a certification. Cobb Fire was the first one in the U.S. to actually take that and be certified. So now we're all certified, and so we have 18 guys who we have canine-specific equipment that's with them, so that way when they're on calls, we have at least 18 guys. The state of Georgia only has a Good Samaritan law. I was trying to create state law, and Senator Kirkpatrick was the champion, and she discovered that there was a Good Samaritan law. The problem is nobody can give a clear definition that with our little Good Samaritan laws, me as a paramedic, can I intubate that dog?
Right.
And so that's where we're at now, is still trying to get city agreements. That way, if something happens in one of the city's canines, our guys can legally touch them. I mean, we can touch our guys because it's easy. We're a county employee touching a county asset, so we can take care of the dogs. But I'm still working on state law that way it can help any of these companies. Because like I've tried to help DeKalb, Georgia Tech, and other places. The problem is the Georgia Tech dog, you're going to have Atlanta Fire come. Well, Atlanta Fire can't touch that asset. So there's a lot of stuff that legally needs to be fixed.
Right.
I was helping Forsyth this year, and Forsyth was able to do it where their oversight and their county commissioners and stuff was like, oh, you guys can treat everybody. So they're in the process right now. They're hopefully got it up and running. So, yes.
Because there are laws in the books right now where if a suspect injures or kills a canine officer, they can get the death penalty for that, can't they, in Georgia?
Correct. Because that officer legally, that dog is looked as an actual officer.
Right.
So, yes.
Wow. So we're a little behind.
It's nationwide. Out of nationwide, there's only 11 states that actually has a law in place that says an EMT or paramedic can do whatever their scope of practice is for that canine medicine.
Wow.
Yeah.
What is the scope of practice, though?
Well, that's the thing.
Is it defined at all?
Well, not in the state of Georgia. You have to define it, and that's why I helped Forsyth set it up with a medical director and universal protocols. Maine has the best one called Neuro's Law. They had a canine officer neuro get injured, and the handler got shot at the same time. The local EMS was like, well, I don't know how to do canine medicine. I can't touch them. And so they had to wait for another handler to get on scene to be able to get the dog, to be able to treat the dog, to transport the dog, and the dog ultimately succumbed to his injuries.
Wow.
Neuro's Law says if there's no more humans on scene to be treated, you, as your scope of practice for that state, can treat the canine officer. Now, they took it a little bit farther. They actually do search and rescue dogs and that kind of stuff.
Right.
So I tried to water our law down to where it's just for canine officers. Let's get that law started, approved, and then we can
expand it later. Wow. So what are the clinical differences between treating a canine and a human?
So the biggest things that surprised me was the intubation. It's harder to intubate a dog. The dog's taking big gulping breaths. It's like any human. You almost throw the endotracheal tube. It's the size of the tubes, right? And then I thought, going up to New York, I was like, oh, man, I've been this 30 years. I can decompress a dog and I can do an IO. The IO landmarks are so different and it's a lot harder. And then you got to take into play the skin. You've seen your dog. It's so leathery and thick skin. So you got to modify it. You got to find that tiny landmark. You got to get through the skin first. You got to hold up the skin. And it's comparable to drilling into a brick. It's a lot harder to do an IO.
Yeah.
And then the decompressions, I probably have decompressed hundreds of people. I was like, oh, I could decompress. Dogs are so much different, the way their lungs are and the way the fenestrated are with their chest cavities. You got to have smaller gauge needles, like 23 gauge butterfly needles, and you have to come in at smaller angles. There's different ways of figuring out which rib to go over. You have to be higher up, and then you have to use 60 cc syringes to pull the air. Dogs can handle a lot more pressure. So one of the dogs I decompressed during my clinical rotations, I ended up pulling off 640 mLs, and that dog was barely panting. And they were like, oh, no, you got to decompress him. And so it shows you how much tougher dogs are.
Wow.
We would have had a collapsed lung and been in cardiac arrest.
What are the top 3 assessment mistakes? What are the assessment mistakes?
We always teach people the March algorithm on all traumas, massive hemorrhage, airway, respiration, circulations, and head injuries or hypothermia. The biggest mistake is not adding an extra M. One of the first things we had to do was make sure our guys knew how to muzzle and control a dog. Because you're talking, these are...
A wounded animal is going to...
Oh, yeah. And then remember, every organization take out the bomb... Well, can't take out bomb dogs because some of them are Malinois too and German Shepherds, and they'll eat you alive. But a lot of these dogs are truly bite dogs. And so these dogs are designed and trained to attack people.
Right.
And then now all of a sudden this dog is wounded. And these are vicious, Malinois especially. They eat you alive.
Let me put that tube in there.
Yeah. So, you're having to learn. Our biggest thing was, hey, if the handler's down, somebody's treating the handler's gone. Let's say there's not another handler and you've got to step up. Our biggest thing was during clinicals finding dogs where our guys had to learn how to control them, how to get that muzzle on, and then the different types of muzzles. So in case the handler's not there and you don't have his basket muzzle.
Wow. What does shock look like in a dog versus crashing?
Well, that's the beautiful thing. So go home to your dog if you have one and just lift up that big old gum, right? When you lift up their lip, their gums, they're so more well perfused, and it's so easy, believe it or not, if you can get to the gum. And that's the key.
Without losing a finger, right?
Yes. But even then, dogs, believe it or not, like you can go down to their vulva and simply open it up, and that, hey, man, it's pale, it's cyanotic. Okay, this dog is struggling. I get him oxygen. And same thing with the male dogs. Hey, what does the penis look like? So dogs have certain conjunctiva that can actually lead you down your assessment road easier, because it's not like you're going to be kind of listen to breath sounds. Speaking of that, like the equipment, when we were looking at rolling this out, I said, well, we can't go out and buy a veterinarian pulse ox, right? So we use Zoll monitors. So I said, well, let me go find every type of attachment and then go experiment on dogs. We had to buy one ear probe from Masmio to attach to our Zoll, where we could get a good pulse ox on either their ear, lip, vulva, penis, whatever, so that we could actually, hey, this is what our pulse ox is. And does the end tidal work? Absolutely. We proved you can put an end tidal on a dog and you can actually see everything. So it was easy for us to modify our current equipment to help us out with the assessments, because it's not like you're going to listen to the dog's breath sounds. We just don't have enough time and enough. I mean, we're going to send guys to clinical every week to make sure they understand what the breath sounds sound like, and it's not going to happen.
Yeah. You don't really have many dogs that are chronic smokers either.
No, not these guys.
If you're going to put together a kit to treat canines, what would be some of the equipment you'd put in a kit if you're going to build one?
So, depends. Are you looking from a BLS or ALS standpoint? If you're BLS and you're talking about trauma, the biggest thing I would add on there, we all had cat tourniquets, and we were all like, oh man, cat tourniquets don't work on canines. The biggest thing we had to make sure all the handlers had was SWAT tees. SWAT tees work beautifully to control any isolated limb bleeding. We had to put in SAM splints. If we had one of these dogs, particularly we have dogs for the fire investigating side, let's say they fall through the second story of a house and break their leg, we had no way to splint. So we had to come up with a splint, and we were able to do that. So from modifying our equipment, we carry most of the same human stuff minus endotracheal tubes. Those tube sizes are monsters, especially if you're talking about a Malinois. I mean, the tube was like 2 feet long. Everything else we already had. I tried to see what was the least amount of equipment. Pediatric electrodes is how we get our EKG on canines. You just go off their pads of their paws. We had to modify by just that one Massimo ear probe, which they use in surgeries, and we just use that now for our canine officers. But otherwise, we already had all the same catheters, the same IOs, and everything.
What does an EKG look like?
Believe it or not, it looks like us. The difference is they have a lot more sinus arrhythmias every time they're breathing.
What am I not asking here?
Believe it or not, we didn't have to, even if we needed to put a chest seal on, believe it or not, our current chest seals were actually fantastic. We used the hyphen, and you can either shave the dog or you put the hyphen on. Dogs can handle a lot more air before they ever get to a tension pneumo. So we weren't overly worried about that. It's all hemorrhage control. Every human medication you can use on a dog, most of the time it's just pediatric dose. So it's the same with TXA.
Yeah. Well, you've got a lot on your plate between these two projects. Well, thank you so much for coming in today. You are definitely a credit to your community and to the fire service, to EMS. There's no doubt about that. You are right up there on the cutting edge of healthcare. And are we first responders or are we healthcare? Probably a little bit of both, but when it comes to the healthcare side of things, you're right up there. I thank you so much for coming in and doing this.
Well, I appreciate you inviting me in, and thank you for this opportunity.
Thank you for listening to In Service, the EMS Podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.